Welcome to Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we talk to international experts who share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartle. I'm an otolaryngologist and head and neck surgeon at the Gustave Roussy Cancer Center in France. And it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all her hard work on making these podcasts a reality, and congratulate Janice and all of those who have contributed to the success that these podcasts have become. We created this podcast to provide clinicians with short, easy-to-digest highlights of clinical issues that we all face while treating thyroid cancer patients. Our aim is to share evidence-based information as well as practice-based experience and tips from world-renowned experts. In each episode, I am joined by distinguished international guests who bring their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, I'm thrilled to have Dr. Carrie Cunningham join me for this podcast. Together, we will explore the hidden burden of financial toxicity in thyroid cancer, how it affects patients' lives, and how we can measure it and make it less taboo. Dr. Carrie Cunningham is an associate professor at Harvard Medical School and section head of the endocrine surgery unit at Massachusetts General Hospital, where she also serves as a senior scientist at the Institute for Technology Assessment. She is the Association of Endocrine Surgeons Research Committee Chair and Executive Council member. Her research in health services and comparative effectiveness has earned national recognition, including the National Institute of Health and American Cancer Society awards. And she is past president of the Association of Academic Surgery. So let's get started. Thank you so much, Carrie, for joining me today. I am really excited because I think it's an amazing topic. And I do feel guilty. I don't think about that sort of thing all the time in terms of what our patients are going through. I'm interested to hear your thoughts about this metric that you've been developing on financial toxicity. You've developed a tool to objectify and quantify this problem. So what made you think about this? What motivated you to develop this, the concept and this score, this metric?
Absolutely. No, thank you for having me, first of all, and bringing this topic to light. It's interesting. This sort of came from my research in looking into cost effectiveness of populations and in the population of thyroid cancer patients and mostly survivors, right? Because most people live a long time with their disease. And it came to my attention that there was very little literature on thyroid cancer costs, to societal costs, resources, and things like that, and to the patient in comparison to these other, what you would conventionally think of as very expensive, with chemotherapies and lots of external beam radiation, et cetera, hospitalizations for infusions. And I started thinking a little bit more about it. And while the costs of thyroid cancer may not be high in the first year, over the length of a time for a patient, 20 years, 30 years down the road, that they still need surveillance and potentially recurrence treatment, et cetera, that it's not that it's cheaper, it's just that it's spaced differently in different phases of their disease. And unfortunately, some of the other cancers, a lot of patients don't survive very long. So I initially started looking at costs of thyroid cancer. And then once I started working on this, I do microsimulation modeling, which is my way of simulating a population of, right now, American patients with thyroid cancer and thyroid nodules, and trying to see which of our interventions are that help patients overall and help the population, or are just costly and harm them. So a very simplistic way of looking at it. And in order to do that, I need the denominator, which is something called a QALY, or quality adjusted life year. And the way we get QALYs, you'll be familiar with them because they use them a lot in Europe, but it's a way of assessing the quality of a year, right? So if someone's living a year with very poor health, maybe undergoing chemotherapy or last year of their life, the quality adjusted year for that would be much lower, zero point 0.3, zero point 0.4 of a year. And so in order to gain those actual numbers, those objective numbers, we use what's something called an index, which is basically a survey of a few questions that ask patients whether or not they're having certain within body experiences, right? So something similar, pain, difficulty mentating, depression, things like that, right? So different characteristics. And there are a number of what we call generic indexes. It used to be conventional when we're using these instruments to be able to use them across the entire population, right? So someone with coronary disease, someone who had a stroke, someone with cancer, right? To use the same questions. But over time, it is what I did another study, which took another 5 years to complete, which was using those standard metrics. So there's something called the EQ5D, which you'll probably be familiar with, which is a 5-question index, which has been validated all over the place. It's a very good metric, and a couple of others. And what I did we looked at patients who were pre-op, 2 weeks post-op, and 6 months down the road. These are real patients prospectively with papillary thyroid cancer. We try to keep it sort of succinct. And what we learned over a long period of time of collecting this is that almost all of those generic indexes, the ones that were supposed to be used across the population, they had a ceiling effect, meaning that the patients, based on the questions they were asking for thyroid cancer patients, they were all basically in perfect health, right? There was very little movement. So that doesn't mean that thyroid cancer patients, I loathe patients being told that they have a good cancer. No one has a good cancer. And what it indicated is that the metrics we were using were not effective, right? It doesn't mean the patients don't have difficulty. So that moved on to the next 5 years of the research, which is to develop our own instrument. And that's to what you were referring. And it is important that we capture, and we had a bunch of experts, both at MD Anderson and here with our group, looking at which elements are really critical. One of those elements, and we're finally getting back to financial toxicity, is it has been shown, there was an article came out showing that bankruptcy in thyroid cancer patients in the United States was higher than other cancers. And we were, thinking about why is that true? And the thought is that because younger people get thyroid cancer, right? So usually when you're out of college or out of university for you don't have a lot of savings, right? And some people don't have health care. I don't think I had health care at that point in time. And so then when you're charged with a huge medical bill, you develop debt, and then that is a positive, a forward process where you're already in debt and you continue to be in debt. So that's sort of the definition of what is the financial burden or we call it toxicity on patients based on the healthcare they're receiving. And so we are integrating that as one of those, we call them domains, right? So one is sort of physical stuff. We have financial toxicity. Another one is sort of depression, anxiety. We've considered using fear of reproduction or changes in reproduction. So these are voice and swallowing changes, things that are very specific to thyroid cancer patients. And we're in the process. We're in the final phase of that, developing it, and hopefully we'll be able to put that into use. And we call it ThyQuali, THCOLI. But we'll have that soon, and we can talk about it on the TIRO podcast. But that is a very long answer to why I'm interested in this.
That's amazing. Yeah, thank you so much. Well, we do kind of see it when we're trying to use, for example, the head and neck cancer questionnaires for thyroid cancer, and we just see that they're not adapted at all. And your questionnaire has, we're thinking about young patients who maybe then want to buy their home or open a business, and even if they're not in debt, you have a metric that measures maybe problems getting a loan and things like that. In France, we have an interesting law that says for grade 1, younger stage 1 patients or older stage 1, stage 2 patients, after 3 years without any disease, the financial institutions cannot overtax them and cannot deny them credit or things like that. And is that in some of your financial metric?
It's interesting because governments change, as we know, and things that are supported and not. As you may have heard, the American health insurance system is complicated, and we have our public, our Medicare, Medicaid insurances, and then the vast majority have private insurances, and those are all over the map. So what we do, at least for cost effectiveness research conventionally, is that we use some that we call them Medicare reimbursement rates, but it's just a way to normalize the costs across all these different insurance platforms. We do not have a law like that in the United States. It sounds like it's very important, like for reasons, there are some people here in the United States that fear getting genetic testing because if they have a genetic mutation, the fear, let's say for breast cancer and they have a BRCA mutation, getting insurance without it going up, it's like getting in a car accident, right? Your insurance goes up, right? And no, I wish we did, but we do not have that protection here in the United States.
And have you seen that for medullary patients too, maybe saying, no, I don't want to know?
Yes, or their
It's
kids.
very,
Yeah.
very tough. Yeah, very, very tough. So just the next question, I guess it's maybe a little bit technical, but so you described the stages of realizing that the way of measuring this wasn't right, and so now you've got a way to measure it. And so you've developed this questionnaire, and then you sort of have to validate it. Is that then you have to ask, give it to all kinds of patients?
Exactly.
How do you go about that? It's a lot of it's a lot of
It
work.
is a
It's a lot of
whole,
work.
every time I come up with an idea, I learn about a whole new discipline and the discipline of basically test development, right? So if you're learning how to take our board exams or you're learning how to do anything that will be able, there are different metrics used for questions, whether or not there's a wide spread of responses. So response distribution. So it's complicated, but I will say in our group, we tested a few questions that hit each of these domains and had patients respond to whether or not which one was easier to understand, right? So we asked them basically about the questions, how difficult they were to interpret. So we did 50 cognitive, and then we have about 200 in the first phase, which is to run them through the questions, right, to actually get their responses. And the next thing we do is compare these to very sort of mathematical ways of assessing utility or quality of life, something called a standard gamble and a time trade-off. These are very formulaic but important to basically testing the questions. And so it's a complex process. But the important thing that you brought up is that it was important to me that we're able to use this across the different subtypes of thyroid cancer. So and we also included our friends at MD Anderson Cancer Center, and Libby Grubbs is my colleague out there who's leading the charge out there, so that we have a different population of patients. And so maybe different health literacy, different financial, socioeconomic status, et cetera. And we're including patients with anaplastic thyroid carcinoma, papillary, follicular, medullary, some that are just diagnosed, some people who are survivors down the road for about, we limited at 10 years, but we're trying to assess this, make it useful for the entire time period of some course of someone's disease.
Okay, so like I said, lots of work. So really specific to thyroid cancer, only thyroid cancer. I'm thinking about your module, the financial toxicity part, that I work at a cancer center. We, vaguely we sort of realize that it's hard on patients, but really don't measure it. Do you think that module would be exportable or applicable in other types of cancer and good cancers, quote unquote, bad cancers? Well, I mean, any ideas on that?
The group, the EORTC, the European group, has they're just fundamentally a fantastic group. And they're even, I believe, trying to develop an index for thyroid cancer as well. So all of their instruments are fantastic and well validated and, vetted and all those other things. I think that you have to compare different diseases, right? If someone has 6 months to live, they're not worrying about their financial, well, I think in general, right? That element or that contribution to their quality of life. It doesn't mean that I often say suffering is not a competition, right? So people with thyroid cancer, the things that impact their lives are different. fundamentally than someone who has a terminal, within the year diagnosis. And so yes, do I think there's an instrument? I know there are people working on this for financial toxicity. I believe this is the first time it's ever been used in a clinical fashion in terms of an index. So it is something very new to include this. Usually these indexes we say are within body, meaning they have, pain, difficulty swallowing, like how do I feel within here, my head, anxiety, depression. Each of these domains is supposed to be in and of itself separate from the other. You can hypothetically have financial toxicity and no pain. You can have financial toxicity and no depression, right? These things have to be independent of one another, which is different from a psychometric survey, which crosses over on purpose. This is purposefully, we call it parsimonious, right? There are very few questions that really focus on one element of someone's quality of life.
Yeah, that's very clear. Thank you. And I think that's what's really interesting about the way you've developed it is to have these different, looking very, very specifically at different aspects of it. Okay, this is maybe a trick question, but do you think it's generalizable maybe to other health systems? You've said there were, different, there are actually different ways that people are covered in the US too. So I imagine that you're touching on all of that kind of.
That is the hope, is to compare one of the uses of this, my model and our group, is to be able to compare one health system to another, on a population scale. What if we stopped surveying people after 5 years of no growth of cured cancer or whatever that we determine that to be, right? Does someone with a benign thyroid nodule, for that matter, need to have an ultrasound every year for the rest of their life, right? That is a huge cost saving. It's kind of joking. I say it's like the Starbucks, right? You pay a little bit of money, but you pay it over and over and over again, and that adds up. It's why I feel so passionate about using a population-based model, because you have to consider the impact, the diagnosis and treatment and follow-up of patients with thyroid cancer in the same milieu as benign nodules that are misdiagnosed and medullary at the same time. And so I think it's really important to consider. It's easy enough to say, okay, if we have a 1 centimeter nodule and it goes X, Y, and Z, this is a better strategy. But that's just not how the world works, right? And it takes a while to diagnose it, and it takes a while to, maybe someone has difficulty finding a surgeon close by. Maybe they live in a rural area and have a hard time getting into their, all those sorts of things. I think our cancer center here at Mass General does a little bit better of a job at asking those questions, right? But we're not great at it. Really, the things that impact people's lives the most are things that are not related to their disease, right? Overall, it is, can they afford to get the health care? Can they get here? Are they taking care of other people at home? Or, how are their kids? Those sorts of things are really impact someone's quality of life. And for better or for worse, we're very focused on that one element of their life. And honestly, we probably don't have time to, take the entire framework, but I'm hoping that this is one element of care that we can measure a little bit.
Yeah, that's really great to be able to do that. And then with, I guess I was going to say artificial intelligence, that's the key word nowadays, and on all the data management that's progressing so fast. I think you picked a really good time to be developing these domains. Yeah.
It's really important, and it's, evolving so quickly. It's interesting. My research group is called the MGH Institute for Technology Assessment, and I'm the only surgeon in the group of 8 to 10 principal investigators. Most of them are are PhDs who work in this field all the time looking, and they've been using AI for a while. The fascinating thing about AI is that it can learn. So the hardest part about doing these models, I mean, my thyroid cancer model is 30,000 lines of code, right? I have a postdoc who's working on it nonstop, and I've been working on it for 10 years. Like, it is complicated. The thing that AI can do is it can actually learn to code, which is, you'd say, I need a program to get me, the standard deviation and whatever, something very simple, but you can also have it learn as you're going along. And so it is definitely something that we are looking at using to do the modeling, right? So it's just fascinating. And that's one of those things that AI can save a lot of time. I was listening to someone from Microsoft in Europe talk about this, and he said AI is not going to completely replace human beings. It is going to allow more time for the creative aspect or the questions you're asking, and not the menial, okay, let me put in all my references and let me structure this, and all those things that take time, but they're not meaningful, right? So hopefully we can do it safely and get to be more efficient. I don't know. We'll see.
That is absolutely terrific. So another question, I want to be better. Do you have some ideas? Do you have a quick fix? How can I be better as a physician to combat financial toxicity, for example?
Having been in practice now for 16 years, I feel like I can speak a little bit to that. And I'm sure that each patient is a little bit different, right? And I try to get a sense of how anxious a patient is, right? So that patient I will follow up more regularly, right? There's still that dynamic bedside manner and relationship with your patients where you can get a sense of, okay, I always ask them personal questions at first also. So like, oh, how'd you get in here today? Those sorts of things. Or if someone they live in Maine, which is really far away from where I am, and they're used to driving 3 or 4 hours just to get to the doctor, I'll say, we can do a virtual call this time, and those sorts of things. Because I think those help. Can I say I ask them about their finances? I don't. I really don't at this point. And even talking here today makes it's taboo, I think, to ask someone about their financial situations, or we think it is culturally. And I think there's a kind way that's not shaming, but more compassionate to ask those questions. But that's a great field for other people to look at. I think what I'm trying to do is sort of make it okay on a global scale to ask about it, right? It's like talking about mental health, which I do also, is that make it a topic of conversation so that other people think that it's okay to talk about, or they feel more comfortable talking about it. Safe space, create a safe space for them.
Well, yeah, that's terrific, though. Breaking the taboo is just so that patients would feel comfortable talking to us about it. I mean, and even if maybe we can't help them concretely, but at least give them that kind of support and eventually get them into contact with people that can.
Maybe we start the conversation with, I was just on a podcast talking about, that the finances are a challenging thing for patients with your disease. I'm curious as to, how this impacts your daily life, something like that. I don't know. That's a pretty easy question, and sort of says, oh, we're talking about this. It's known that patients with thyroid cancer, right? So that people don't feel shame or singled out, so I think that could be a pretty easy way. I'm going to start doing that. I'm glad we did this today.
That's terrific. Well, and I really appreciate it. I totally agree. It's a relationship. It's the relationship. And if the patient feels like you care, knows that you care, then they'll maybe also feel more comfortable, expressing things like that and anxiety or whatever's going on. So to wrap this up, this has just been delightful and just so amazing. So with all of your experience in this, do you have any other words of wisdom, anything that you want to say to our listeners today?
I think that what I would like to do, because these are clinicians, right, that we're speaking to through TIRO primarily, is to continue. I know it's difficult to do research these days, and to continue to collaborate with people from other countries. And I think that is when we were at the World Thyroid Congress, I was just amazed at the different groups. There was a whole session on finances and thyroid cancer, and there was a group from Sweden, and there was a group from Holland, and one from Iraq. And it was these people all in different silos. The one great thing about the web is that we can talk on Zoom and we can collaborate. And so I'm going to get that index to you as soon as it's out. Dana, we'll have you checking out some French patients as well.
Wonderful. With pleasure, with pleasure. And we will, I think all our listeners and myself will be looking at your publications and your work as things unfold. So thank you so much for joining us.
It's been a pleasure, and thanks for bringing this as an important topic.
And that brings us to the end of this episode of Voices of Wisdom. I'm Dana Hartle, and it has been an absolute pleasure to host today's exploration of the hidden burdens of financial toxicity in thyroid cancer. I want to extend a special thank you to my guest, Dr. Carrie Cunningham, for spending time with me today and sharing her wisdom and insight into this really very interesting question. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting season ahead of us, so please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars every Friday morning at 8 a.m. Eastern Time. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. Just visit tyro.expert/subscribe or click the link in the description. Thank you for tuning into this episode of TIRO's Voices of Wisdom podcast.